Welcome to the introductory training entitled California Advancing and Innovating Medi-Cal, CalAIM 101. The goal of this 50-minute training is to introduce and inform you of the role and value of community supports and enhanced care management, ECM, within the larger context of CalAIM. California Advancing and Innovating Medi-Cal, CalAIM, is a giant undertaking, aiming to bring about significant, multi-layered change and expansion to California's Medicaid program. The CalAIM implementation began in January of 2022, and the rollout is scheduled to continue in phases through 2027. Given its magnitude, learning about CalAIM can initially feel like a daunting and overwhelming process. The terminology and associated acronyms alone can take time to absorb, especially if CalAIM is new to you. This training is a starting point and covers the basics of CalAIM, focusing on what community supports and enhanced care management providers need to know as they begin serving their communities in new and better ways. Today, our training objectives will be: Number 1, to describe the history, goals, values, and components of CalAIM. 2, to understand how the Medi-Cal service delivery system is changing under CalAIM. 3, to define community supports and enhanced care management and how they function to strengthen care under Medi-Cal. And 4, to highlight key responsibilities of community supports and ECM providers. Our covered topics today will include overviews and explanations of the vision and goals of CalAIM, Medi-Cal, including CalAIM waivers, managed care plans, population health management, social drivers of health, providing access and transforming health, health-related social needs, community supports, whole person care, enhanced care management, or ECM, and responsibilities of community supports and ECM providers. The state of California's vision for CalAIM is to transform Medi-Cal to ensure that Californians get the care they need to live healthier lives. The goals of CalAIM are to address California's physical and mental health needs, improve and integrate care for Californians, be a catalyst for equity and justice, work together to build a healthier state. This training will explore these goals in more detail, defining key concepts and providing specific examples to further illustrate their meaning. On the most basic level, CalAIM is about health, which the World Health Organization defines as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. This definition alone speaks to the concept of health as a dynamic, multidimensional, broad, and holistic concept. CalAIM is particularly concerned with the health of low-income Californians, which means that learning about CalAIM means learning about the impact and intersection of health with other economic and social factors. Ultimately, CalAIM widens how health is defined and how healthcare is delivered, managed, and improved for people with Medi-Cal. Medi-Cal is California's version of Medicaid, the federal health coverage program for low-income individuals. Medicaid, which was enacted by the Social Security Act of 1965, is overseen by the Federal Centers for Medicare and Medicaid Services, or CMS. The program is jointly funded by the federal government and states. In its Medicaid state plan, California's Department of Healthcare Services, the DHCS, enters into a formal contract with CMS and receives federal reimbursement for meeting certain requirements. This Medicaid state plan also sets forth California's eligibility criteria, benefits, and overall administration, which are unique to each state. California has the nation's largest Medicaid program with over 15 million people enrolled as of July 2023. Medi-Cal covers 3 in 7 of the state's children under 18, as well as 2 in 5 people with disabilities. Any significant change to a state's Medicaid program must be formally approved by the federal government. A state can request changes by either an amendment to the state's Medicaid state plan or through a Medicaid waiver. 2 CalAIM waivers, along with Medi-Cal state plan amendments, enable California to fully execute CalAIM initiatives. 2 sections of the Social Security Act, Sections 1915 and 1115, allow for waivers, which permit CMS to waive certain aspects of the law to enable states to test different approaches to program eligibility, benefits, delivery systems, and financing. Section 1915 program waivers focus mostly on a state's implementation of Medicaid managed care delivery systems. Section 1115 demonstration waivers advance experimental or pilot projects that further the objectives of the Medicaid program and allow states to cover non-traditional medical and non-medical services. The most significant requirement for CMS approval of waivers is that of cost-effectiveness or budget neutrality. The Medi-Cal Policy Institute emphasizes it is no small task for an individual state to modify its Medicaid program. The CalAIM changes approved by CMS represent years of strategic planning, stakeholder input, and meticulous financial analysis, demonstrating California's commitment to a more coordinated, person-centered, and equitable health system. In its approval letter for the CalAIM waivers, the Federal Centers for Medicare and Medicaid Services commends California for taking bold steps to achieve its vision. These bold steps relate to all components of the Medi-Cal program, aiming for major changes across clinical, administrative, financial, and technical functions. Some examples of these changes include how Medi-Cal enrollment and benefits are administered, how Medi-Cal services are paid for, how Medi-Cal services are delivered, who provides Medi-Cal services, what services and benefits are covered by Medi-Cal, who is eligible for specific services and benefits, and how data is used and shared among Medi-Cal providers and systems. Enhanced care management and community supports providers may be new to working under Medi-Cal. Part of the vision of CalAIM is to break down the walls of healthcare, which includes the expansion of who is able to provide healthcare services. All Medicaid providers must follow some overarching principles in their service delivery, which are reflected in the policies for enhanced care management and community supports. Services must be provided to Medicaid beneficiaries based on individual assessments of need, rather than a one-size-fits-all approach. This principle is reflected in the Enhanced Care Management core component of Comprehensive Assessment and Care Management Plan, as the process results in a comprehensive, individualized, person-centered care plan. Additionally, housing-related community supports require an individualized housing support plan. Services are expected to meet the beneficiary's needs in the most economic and efficient manner possible and are of high quality. ECM and community supports providers should implement or strengthen policies and procedures to reduce fraud, waste, and abuse, as well as ensure that direct service delivery staff receive ample training, supervision, and support in their roles. Medicaid is frequently, but not always, the payer of last resort. As such, providers should consult the DHCS policy guides for ECM and community supports to understand any limitations and/or exclusions related to the payment of these services. California's Department of Health Care Services, DHCS, contracts with various organizations referred to as managed care plans or MCPs, to deliver Medi-Cal-funded health care in a designated county or counties. As of January 1, 2024, DHCS streamlined all contracts into one standard agreement, establishing rigorous new standards of care and greater accountability for MCPs. Medi-Cal Managed Care operates in all of California's 58 counties and provides coverage for about 88% of people with Medi-Cal. MCPs have networks of providers to offer most Medi-Cal state plan services, including primary and specialty care, as well as mental health services for members with mild to moderate conditions. Examples of contracted managed care plans include Kaiser Permanente, HealthNet Community Solutions, and Molina Healthcare of California. One of the new contract requirements is for managed care plans to offer a robust and comprehensive population health management, or PHM, program, as historically, many MCPs offered only partial components. The intention of PHM, as part of DHCS's overarching comprehensive quality strategy, is to ensure that all members, children, their parents, pregnant persons, elderly and other adults, and people with disabilities have access to a whole system, person-centered program that leads to longer, healthier lives, improved clinical outcomes, and a reduction in disparities. With a reliance on program and outcomes data, population health management continuously evaluates and responds to the whole person health needs and risks of each individual, as well as the Medi-Cal population at large, including groups with recognized health disparities. A guiding PHM principle is the quadruple aim. Number 1, enhance the patient experience. 2, improve population health. 3, reduce costs. And 4, improve the work life of healthcare providers. A primary intention of the Population Health Management Program is to identify and mitigate the social drivers of health. The World Health Organization defines the social drivers of health, also known as the social determinants of health, as the non-medical factors that influence health outcomes. They are the conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the conditions of daily life. The Center for Disease Control groups these drivers into 5 categories: economic stability, education access and quality, healthcare access and quality, neighborhood and built environment, social and community context. The social drivers of health strongly influence a community's health and life expectancy and also contribute to health disparities. The Medi-Cal population at large, based on income level and other factors, is generally disadvantaged when it comes to these social drivers of health. As part of its population health management program, managed care plans are required to conduct a population needs assessment, which includes the collection of SDOH data, such as data on income, housing and homelessness, education and academic achievement, social environment and public safety, and transportation. The population needs assessment allows the plan to identify and address the social and health needs of its members at the community level. In addition to conducting a population needs assessment, managed care plans are also required to have a basic population health management, or BPHM, program. DHCS describes basic population health management as an approach to care that ensures needed programs and services are made available to each member, regardless of the member's risk tier, at the right time and in the right setting. Examples of BPHM components include access, utilization, and engagement with primary care. As part of the new contracts, managed care plans must identify and follow up with members who are not receiving primary care services. These services are covered by Medi-Cal and critical in preventing and/or managing health conditions. care coordination, navigation, and referrals across all health and social services, including community supports. Under closed-loop referral requirements that go into effect in January of 2025, managed care plans may not simply refer members to needed health and social services, they also must ensure the members actually receive those services. Wellness and prevention programs. These programs promote essential elements of wellness and prevention, such as healthy weight, healthy eating, exercise, smoking cessation, and stress management. Programs addressing chronic disease. Managed care plans are now required to offer evidence-based disease management programs, specifically targeting, at minimum, diabetes, cardiovascular disease, asthma, and depression. Programs to address maternal health outcomes. These programs address, for example, the fact that maternal mortality for Black birthing persons remains 3 times as high as for white birthing persons. Also, as of January 1, 2023, doula services are now covered by Medi-Cal upon recommendation by a licensed practitioner. California's Bold Goals 50 by 2025 initiative for population health management brings together prevention efforts as well as the remediation of specific health disparities. The National Institutes of Health defines a health disparity as a health difference that adversely affects disadvantaged populations in comparison to a reference population based on one or more health outcomes. The goals of this initiative are 5-fold. Ensure all health plans exceed the 50th percentile for all children's preventative care measures. Close racial ethnic disparities in well child visits and immunizations by 50%. Close maternity care disparity for Black and Native American persons by 50%. Improve maternal and adolescent depression screening by 50%, and improve follow-up for mental health and substance abuse disorder by 50%. These bold goals illustrate that population health management and CalAIM at large are at their core a social justice endeavor. The World Health Organization emphasizes the enjoyment of the highest attainable standard of health is one of the fundamental rights of every human being, without distinction of race, religion, political belief, economic, or social condition. CalAIM exists to ensure this fundamental right of health for all Californians. Our training today focuses on the bold steps of CalAIM's Enhanced Care Management, or ECM, and community supports, both of which serve Medi-Cal recipients with significant medical and social challenges. These initiatives are based on how care is managed across the entire Medi-Cal population, or population health management, and how care is provided at the individual level, whole person care. ECM and community supports are, however, just 2 pillars of change within a much bigger picture. Here are some examples of other important components. Services and supports for justice-involved adults and youth allow individuals in state prisons, county jails, and youth correctional facilities to now receive certain Medi-Cal services 90 days prior to their release. The strategy to support health and opportunity for children and families addresses the fact that Medi-Cal covers more than 50% of California's children. It aims for stronger pediatric preventative and primary care, streamlined access to vaccinations, and improved care to foster youth. The behavioral health transformation is designed to better integrate mental health and substance use services with the physical healthcare system, as well as simplify and streamline documentation requirements and the reimbursement process. New dental benefits include a tool to identify risk factors of dental decay and fluoride treatments for children and certain high-risk populations. These pillars are not all-inclusive, but just some examples to illustrate the scope of CalAIM. California recognizes that the scope of CalAIM demands dedicated resources and support for organizations to successfully participate. The Providing Access and Transforming Health, or PATH initiative, is an investment in the capacity and infrastructure of local community-based organizations to provide services to Medi-Cal members in their communities. PATH is a 5-year, $1.85 billion initiative that provides resources such as staff, billing systems, and data exchange capabilities. Support for implementation of enhanced care management and community supports includes the following 3 PATH initiatives. Number 1. Capacity and Infrastructure Transition Expansion and Development, or CITED. Examples of cited funding activities include increasing the provider workforce, supporting health information exchange and data reporting, and outreach to underserved populations. Number 2. Collaborative Planning and Implementation, or CPI. CPI groups are composed of stakeholders in a county or region that work together to identify, discuss, and resolve local implementation issues, disseminate best practices, and improve outcomes. Number 3. The Technical Assistance, or TA, Marketplace. The Marketplace is a one-stop-shop website where entities can access free technical assistance services from curated and approved vendors. Examples of TA services include hands-on training regarding billing, reporting requirements, and contracting with health plans, as well as guidance for data sharing between providers and health plans. Support for implementation of CalAIM Justice Involved Initiative includes the following PATH program: Justice Involved Capacity Building Program, or JI. This program provides funding to support implementation of pre-release Medi-Cal enrollment and the delivery of Medi-Cal services in the 90 days prior to release. Examples include investments in personnel, capacity, and/or IT systems needed for collaborative planning and implementation. The PATH initiative, as well as CalAIM at large, are both designed to promote health equity. This transformation includes not only addressing the community-level social drivers of health, but also the more focused individual-level health-related social needs. Health-related social needs, or HRSN, are defined as social and economic needs that individuals experience that affect their ability to maintain their health and well-being. These include needs such as employment, affordable and stable housing, healthy food, personal safety, transportation, and affordable utilities. These health-related social needs are a subset of the broader community-level concept of the social drivers of health, which encompasses all the conditions in which people are born, grow, work, live, and age. The concept of health-related social needs zeroes in on the immediate, actionable issues that healthcare systems can address to improve well-being at the individual level. Both concepts emphasize the critical link between social factors and health, but HRSN highlights what can be addressed at the member level to improve care. Federal regulations allow states to address health-related social needs through their Medicaid state plans, Section 1915 waivers, and Section 1115 demonstrations. This flexibility includes coverage of in lieu of services and settings, also known as community supports. Community supports, which are a critical pillar of change under CalAIM, are services provided by Medi-Cal managed care plans as cost-effective alternatives to traditional medical services or settings. Starting in January of 2022, Medi-Cal managed care plans began to take advantage of this Medicaid-covered opportunity. Prior to CalAIM, similar supports were available only through California's whole-person care pilots and its Health Homes program, and only on a limited basis across the state. Managed care plans are strongly encouraged, but not required to offer community supports, which are voluntary to the member when available. Community support services help address members' health-related social needs by offering non-clinical wraparound services that target barriers to health such as housing instability, food insecurity, and transportation challenges. A key function of community supports is to provide care in the least restrictive setting, and avoid medically unnecessary hospitalizations, nursing home stays, and other costly interventions. As just one example, Medi-Cal will now pay for home modifications such as ramps, grab bars, and roll-in showers to support a member living at home and in lieu of, for example, emergency department and home health agency services. These alternative services and settings aim to improve health outcomes by addressing the root causes of poor health, ensuring members receive holistic care that extends beyond traditional medical services. By integrating supports like housing transition assistance, meals, and personal care, community supports directly mitigates the social factors impacting health. 14 types of community supports are now available under Medi-Cal. Each of these types has very specific and detailed eligibility criteria and service definitions, as well as restrictions and limitations. A member's eligibility for particular community support is determined by the managed care plan on an individualized basis that considers the member's unique whole health status and documents the medical appropriateness of the community support. Housing transition navigation services, housing deposits, and housing tenancy and sustaining services help members obtain and maintain safe and stable housing. Nursing facility transition diversion to assisted living facilities and community transition services nursing facility transition to a home will help members to step down from or avoid a nursing facility placement. Medically tailored meals, personal care and homemaker services, and caregiver respite support members with activities of daily living, including management of their medical conditions at home. Asthma remediation, such as dehumidifiers and ventilation improvements, and home modifications, such as stair lifts, improve the member's home environment to support safety and autonomy. Sobering centers, short-term post-hospitalization, dehabilitation, and recuperative care or medical respite allow members to receive care in the most clinically appropriate and least restrictive setting. In many ways, CalAIM involves re-examining and redefining the meaning of health, as well as the elements, functions, and scope of the healthcare system. Its whole-person care approach is rooted in the concept of whole-person health, defined by the National Institutes of Health as looking at the whole person, not just separate organs or body systems, and considering multiple factors that promote either health or disease. This definition views disease and health on a spectrum, and as a reflection of each person's complex, dynamic, and ever-evolving interaction among physical health, behavioral health, and the social environment, i.e., community supports. Whole person health moves away from disease-focused treatment towards care that acknowledges each individual's unique strengths, preferences, culture, and needs within the context of their family, community, and the population at large. Whole person care, as well as population health management, rely on non-traditional partnerships among different sectors of the community to achieve positive health outcomes. A whole person care approach recognizes adverse childhood experiences, or ACEs, as a significant factor in each person's health status. In December of 2019, California implemented its ACEs Aware initiative. While this initiative is separate from CalAIM, it shares the same goal of improving health outcomes. The Centers for Disease Control defines adverse childhood experiences as potentially traumatic events that occur in childhood from 0 to 17 years. Examples of ACEs include, but are not limited to, experiencing abuse and or neglect, witnessing violence in the home and or community, growing up in a household with substance abuse and or mental health challenges, separation of parents, incarceration of family members. In a landmark study conducted by the CDC and Kaiser Permanente during the 1990s, the findings showed that the more ACEs a person has, the greater risk for negative outcomes in the areas of mental health, maternal health, infections and chronic disease, and alcohol and drug abuse. In DHCS policies around community supports, enhanced care management, and other CalAIM components, a trauma-informed approach, which includes establishing and maintaining physical and emotional safety, trust, transparency, and cultural sensitivity in relationships, is recognized as the best practice for service delivery providers. Starting in January of 2022, for certain populations of focus, enhanced care management became a new statewide Medi-Cal benefit for eligible members of managed care plans. The guiding vision for this benefit is that members will have their basic needs met and live in their communities with health, dignity, purpose, and a sense of belonging. ECM is defined as a whole-person, interdisciplinary approach to care that addresses the clinical and non-clinical needs of members with the most complex medical and social needs. Just as whole-person care involves looking at the whole person, we must also look at the whole system of not just traditional healthcare services, but also community-based social services. As such, coordination and integration of care among a wide array of organizations and professionals becomes the most vital, distinct function of healthcare, particularly for the highest need, most vulnerable individuals who can easily get left out or lost in multiple silos of care. ECM is in part a response to the reality that over half of Medi-Cal spending applies to just 5% of Medi-Cal enrollees. It is also a response to California's escalating homelessness crisis. Each Medi-Cal member who qualifies for enhanced care management will be assigned a single lead care manager who will coordinate care and services among the physical, behavioral, dental, developmental, and social services delivery systems, making it easier for them to get the right care at the right time. Importantly, DHCS notes that it will not set licensing requirements for ECM care managers. Instead, the department clarifies that managed care plans are required to have a process for vetting qualifications and experience of ECM providers. This lead care manager meets members, their family members, and other supports in person, wherever they are, on the street, in a shelter, in their doctor's office, at home, or in other convenient locations, and builds trusting relationships that recognize the member's strengths, needs, and preferences. These preferences include the right to decline or end ECM at any time. This lead, in essence, becomes the ambassador of whole-person health for each member, breaking down any existing silos and integrating care across a wide variety of delivery systems. Like community supports, Medi-Cal managed care plan members must meet very specific eligibility criteria to qualify for enhanced care management. Some eligibility categories are limited to adults, defined as an individual 21 years of age and older, and some are limited to youth, defined as an individual under the age of 21. There are currently 9 populations of focus, with 2 different sets of eligibility criteria for homeless persons. In January 2024, a birth equity focus was added to address high maternal morbidity and mortality rates in specific racial and ethnic groups. Additionally, youth who have aged out of foster care may qualify for ECM up to the age of 26. All ages. Homeless. Includes adults without dependent children, youth living with them, and homeless families or unaccompanied children, youth experiencing homelessness. At risk for avoidable hospitalization or emergency department utilization, formerly high utilizers. Serious mental health and or substance use disorder needs. Transitioning from incarceration. Birth equity. Adults only. Living in the community and at risk of long-term care institutionalization. Residing in a nursing facility and transitioning to the community. Children and youth only. Enrolled in a California Children's Services Program for children with certain diseases or health problems, or CCS whole child model with additional needs beyond the CCS condition, or involved in child welfare. Enhanced Care Management, or ECM, has 7 core components: outreach and engagement, comprehensive assessment and care management plan, enhanced coordination of care, comprehensive transitional care, health promotion, member and family supports, and coordination of and referral to community and social support services. DHCS clarifies that while ECM and community supports may both be appropriate for certain members, they are separate initiatives, and some Medi-Cal members will qualify for only ECM or only community supports. The last core component of ECM reflects the intersection of both these initiatives. For members receiving both ECM and community supports, the lead care manager holds the primary responsibility for coordinating all services and closing any gaps across the member's care management plan. Enhanced care management and community supports providers represent a very diverse group of organizations. In fact, the Department of Healthcare Services discourages managed care plans from contracting with one-size-fits-all clinic-based providers to deliver these services. As part of its own unique model of care, each managed care plan must account for how it will contract with a robust network of ECM and community supports providers to meet the needs of its members. DHCS approves each MCP model of care and any subsequent updates, and it monitors MCP provider networks for diversity and capacity. Providers of ECM and community supports have an existing footprint in the communities they serve, bring experience and expertise with providing similar services to similar populations, and know members best. ECM providers may include county behavioral health providers, physician groups, community-based organizations, rural health clinics, Indian Health Service programs, regional centers, and First 5 county commissions. Community supports may be provided by organizations serving the homeless, life skills training and education providers, county agencies, social services agencies, affordable housing and supportive housing providers, or federally qualified health centers. Upon the launch of Enhanced Care Management and Community Supports, the Department of Healthcare Services established standard requirements across certain areas of implementation. It also allowed an MCP's flexibility in other areas through the model of care process. Because each MCP's model of care can be different, ECM and community supports providers have consistently reported to DHCS that increased standardization is needed to address the heavy administrative burden and significant operational differences between managed care plans. Therefore, in July 2023, DHCS issued a cheat sheet for ECM and community supports providers to explicitly clarify the 3 levels of standardization MCPs must follow. The standardization levels are designated as high, established, uniform, and prescriptive criteria set by DHCS, medium, some MCP flexibility within the DHCS framework, and low, higher level of MCP flexibility or discretion. As one example, member qualifying criteria reflects a high level of DHCS standardization because MCPs must strictly adhere to eligibility criteria for ECM populations of focus. An area of low DHCS standardization is that of payment rates and terms for ECM and community supports, which are currently set by each managed care plan. In August of 2024, as part of its ongoing efforts to reduce administrative burden, DHCS announced the creation of Universal ECM Referral Standards. These standards aim to improve the consistency of information collected by MCPs to process an ECM referral, so that entities making referrals to multiple MCPs have a predictable common set of information they must send on each member referred to ECM. Starting January 1st, 2025, all managed care plans must adopt these new requirements for initial ECM referrals, including updating their referral forms, public-facing web pages, member handbook, and overall procedures to comply with this high level of DHCS standardization. Key MCP compliance areas include electronic and form-based, for example PDF, referral pathways, standardized language about the referral process and eligibility criteria, specific data elements for Medi-Cal member information and referral source information, population of focus eligibility indicators for adults and children youth. Examples of required elements for Medi-Cal member information include the member's managed care plan, date of birth, and primary phone number. Examples of required elements for referral source information include the referring organization name, referring individual name, and referring individual relationship to member. Importantly, managed care plans may not impose additional requirements for reviewing a member's eligibility beyond what is included in the ECM referral standards. Additionally, the self-referral process is simplified for members and families, as a call or other communication to the MCP is adequate to initiate the referral. Medi-Cal managed care plans are tasked with extensive responsibilities in implementing the enhanced care management benefit to eligible members and in supporting and overseeing the work of ECM providers. If managed care plans choose to offer one or more of the 14 community supports, the same responsibilities also apply. Examples include ensuring provider capacity by establishing a diverse and experienced network of providers to serve the anticipated need. Identifying eligible members by reviewing claims, utilization, and other data, and informing members, their families, and community partners about the benefit and how to request it. Responding to referrals and authorizing members on an individualized basis and in a standardized and timely fashion. Referring to a provider who is an appropriate fit to meet the member's needs. Overseeing providers through trainings, technical assistance, auditing, and corrective action as needed. Paying providers as per contracted rates. CalAIM's whole person approach demands the sharing of various kinds of confidential information, such as demographic data, physical and behavioral health information, living situation status, etc., across a wide network of providers and organizations. Managed care plans, enhanced care management providers, and community support providers all have a critical responsibility to meet legal and technological parameters in this data sharing. This responsibility involves navigating a maze of federal and state laws that establish different sharing parameters based on the type of information involved, the purpose of the sharing, the age of the individual, and other factors. It also involves what DHCS calls a tremendous investment in building and expanding an information technology infrastructure that makes use of the highest of security safeguards. In an effort to streamline the consent process and comply with all applicable laws, DHCS is currently piloting a form entitled Authorization to Share Confidential Medi-Cal Information, or ASCMI. This form and a new consent management service are collectively referred to as the ASCMI pilot. The department's long-term goal is that the form and service can be used for all Medi-Cal members and accessed by providers to verify what information an individual has consented to be shared and with whom. Within the complexity of the associated privacy laws and IT security demands, the lead enhanced care manager, as well as community supports providers, need to directly obtain or verify authorization from the member for the sharing of information. Currently, each managed care plan is responsible for establishing its own authorization process and associated requirements in its policies and procedures. This authorization process should ensure that staff working directly with members are able to communicate, in clear and understandable language the purpose of the authorization and to respond to general questions and/or concerns that members might have. Especially as ECM and community supports target historically underserved individuals and communities, taking this time and care helps to build trust and transparency and promote self-determination. To support frontline workforce members, ECM and community supports providers should also designate an individual or committee to build or strengthen expertise in privacy and security matters. This support should include having a formal process, including communication with managed care plans and legal counsel as needed, to vet questions and concerns that will naturally arise in day-to-day practice. In pulling together the topics we've covered today, a key takeaway is that CalAIM dramatically expands the way healthcare is conceptualized and the way healthcare is delivered for people with Medi-Cal. Under the umbrella of population health management, a new standard set of programs targeting all levels of wellness, including chronic disease, is now available to all Medi-Cal members. The enhanced care management benefits, required for managed care plans, and community supports, optional for managed care plans, are available to higher need members who meet qualifying criteria. Healthcare is delivered with a whole-person care approach, addressing the social drivers of health as well as each individual's strengths, needs, preferences, and culture. The California Department of Healthcare Services, in conjunction with managed care plans, lead this transformation, with DHCS providing levels of standardization across ECM and community supports policy areas. At the core of the CalAIM transformation are non-traditional partnerships among DHCS, managed care plans, and community-based organizations with the end goal of improving healthcare quality and reducing health disparities. As ECM and community supports are rolled out across the state and across populations, and as the state moves to implement the various other pillars of CalAIM, it is important to remember that California's path to healthcare transformation is not a one-size-fits-all or one-and-done endeavor. Given the magnitude of these changes, we are all engaged in a collective learning process that will evolve over time. This process necessitates patience, flexibility, persistence, innovation, and commitment on the part of each workforce member. At the forefront is the vision of longer, healthier, and happier lives for people with Medi-Cal. This slide includes key resources and primary references. For a list of all references, including page citations for any quotes, please see the training transcript. Questions about this training can be directed to CalAIM@dhcs.ca.gov.